Hi everyone, thank you for being patient. Sorry for the delay, we're just having technical issues. As you can imagine, we're not very used to working remotely at the moment, so thank you for your patience. My name's Kate Townsend. I'm Deputy Programme Manager for the Quality Network for Psychiatric Intensive Care Units, which is a quality improvement programme run by the Royal College of Psychiatrists. I've got some thing. Hang on. Okay. So we've had a really positive and high volume of responses today, so welcome everyone. And we are of course discussing acute disturbances during the COVID-19 pandemic. And whilst this is going to be a webinar about the guidance that's published, it's also a lot about shared learning, because none of us are experts in this field, and so we all want to learn from each other. So it's obviously a very uncertain time for everyone at the moment, and certainly the implications that this will have on mental health services is largely unknown at the moment. We're looking to hold webinars on a weekly basis, focusing on different themes every week. So if you're interested in attending more of these and you're not on the mailing list, please drop me an email and I'll be happy to add you. A few things just to introduce today. Obviously, we had a couple of speakers that were due to present, but they're having issues getting on this Teams as a presenter. So we're going to be kicking off today with Tom Tunnicliffe and Roland Dix talking about the NAPICU guidance that they've published specifically for acute disturbances within PICU environments. And then hopefully we'll have sorted out these technical issues, and we'll be having Mayura Deshpande talking about the Royal College of Psychiatrists, the secure environments and ethical considerations. And hopefully we've managed to get Geoff Brennan on. He's missing, but we'll have to see how that goes. So just before we start, I just want to let you know that this is being recorded and will hopefully be published on the websites for both the RPSIC and the NAPICU, as this is a joint event run by the two of us, the two programmes. There is a question and answer function, and I really encourage you to do some questions throughout, and we'll be dipping in and out of that throughout the webinar. So other than that, hopefully things will run smoothly, and I will hand you over to Tom Tunnicliffe.
Hello, sorry, need to unmute my microphone. I'm Tom Tunnicliffe. I'm a consultant nurse and approved clinician in PICU, and I'm also a member of the NAPICU Executive Committee and the Quality Network Advisory Committee. Roland Dix is having some technical issues, but he should be available on the phone, so hopefully you'll be able to hear him. Roland?
Yeah, I'm not sure if people can hear me, but I can hear you.
Okay. So what we were planning to do, as Kate said, was to just go over quickly the NAPICU guidance on managing acute disturbance in the context of COVID-19. And then hopefully what we'd like really is some questions and some challenges on it that we can help us develop it further, but obviously also help everybody develop practice a bit. So I think what we were going to do was Roland was just going to go briefly over some of the stages of the guidance and how we got to publishing it really, and then take it from there, I think. So do you want to start with that, Roland?
Yes, I can. Can you hear me okay?
Yeah, I can hear you.
Okay. Yeah, so our journey, if you like, to publishing this guidance, I'm sure is the same as everyone else's in that it was done quite quickly. We didn't really see coming the magnitude and the width and depth of practice development that we would need to be involved in. So using our networks and talking to people and the sorts of anxieties as well as the hard practice questions that came our way, we decided, rightly or wrongly, I would argue rightly, to grapple with some of the most difficult issues, which would be how would one engage with acute disturbance in the context of COVID-19 infection, and in what way would the procedures and resources and interventions available to us already for engaging that very difficult area of practice, how might that be changed, modified, or in what way should it be considered with infection risk as an additional consideration? So we put together the standard sort of formats of primary, secondary and tertiary interventions, which considers COVID-19 as an additional set of considerations in the context of acute disturbance that would probably already exist, in the sense that people who find it difficult to control their impulses or to act in a way that many people might find reasonable because of their acute mental condition. So our guidance is trying to tackle, I think, the harder ends of the questions in the context of code of practice. And the guidance is there, and I'm sure people have read it. And so we can take some questions on it or point out some issues and go from there.
I suppose what we wanted to be clear on is, like you were saying, was to adopt the different stages in the primary and the secondary and the tertiary interventions, and try and make sure that that was clear, and that we should work up in that framework, and that tertiary are the last end of the spectrum and the last options that we should employ. And like you said, the legal and the ethical considerations have been the big issue, really, haven't they? And making sure that we are adhering to relevant legislation where it's available. And I know some of the queries that we've had so far have been related to that, haven't they? So I don't know if anybody wants to ask any questions about that, or have got any queries from their own practice. I think we just use the chat function down the side. If anybody wants to write a question, I can read it out and we can try and answer it. All I've got so far is the sound is fine, or cut the echo out.
I've just turned off, Tom, the app that I think was running in the background, so that might help you echo.
I suppose one question, or one big consideration that we had and that we wanted to try and make crystal clear was that this guidance isn't interpreted as a really blunt instrument that can just give people confidence or authority to just keep everyone in a bedroom or everyone in seclusion. I think what we were trying to say, Roland, one, that was to stress the primary, secondary and tertiary interventions, and still trying to maintain the least restrictive options. Have you had any questions come through, Kate?
Yeah, I'm just publishing them now.
Ah, there we go. So yeah, let's have a look then. So there's some about PPE. Right, we could start on PPE because there's a couple of questions about PPE. So one question saying, considering at least some patients aren't able to follow social distances rules, would it be appropriate for PICU staff to wear basic PPE? And what PPE should we wear when administering rapid tranq to suspected patients? So there is a section at the end of the guidance about PPE, which is still under development, but there's some basic initial views in there. There's supposed to be some more guidance, I think, coming from Public Health England today on PPE, but I know Roland, you're at the moment, I think, testing PPE, aren't you?
Yes, we are. Just to try and answer that question, it's a good question. The public health PPE guidance has been published. I think I've seen the it's a sort of a PDF single sheet, and it gives 1 to 5 levels of PPE, and it categorises mental health environments, I think, in a similar way to other residential settings. So in terms of a PICU, I think full PPE in terms of close contact would be used in PMVA situations where you rapid tranquilization, or for those who use locked door seclusion or extra care areas. For somebody who is suspected very clearly of being COVID-19 positive or confirmed, then we are going to recommend PPE. The way in which it differs from the public health recommendation in the PICU context is that aprons we've tested in real life scenarios, obviously drilled out by PMVA and physical intervention trainers. The aprons come off very quickly, and then they end up being a slip hazard because you stand on and you slip. So we're going to recommend, we've not done it yet, but it will be on our guidance soon, that the apron for purposes of PMVA is replaced with single-use or short-use overalls. We've got veterinary standard overall moments that have been tested and proved viable. We're recommending goggles rather than visors because the goggles stay on, and we're testing a number of products to make sure that they stay on. We're recommending a face mask of the similar standard that is already available, and gloves. So we've got some guidance on all of those issues at the moment. Our PMVA trainers will be testing them tomorrow and on Monday, and we will publish in our guidance what we think is reasonable PPE in the context of physical intervention. And we're going to test people trying to grab the mask and put it away, and some of the more extreme situations you might come across. So we'll be able to add that to the guidance.
Okay. There was another question here that said, in light of the NAPICU guidance, is it expected for each organisation to develop their own guidance? I think a view from that is that our guidance is there and you can use it and deploy it, but I would expect organisations to develop their own sort of protocols from it, their own standard ways of working, and things like that. These are the principles and the suggestions of ways to manage situations, and there's a rationale and a legal basis and things like that for it. So I think it's a sound document for the organisations to then develop their own working procedures from, because each organisation is slightly different. So I would do that, and I would make sure that the ethics committee that NHSE refer to heavily, and that's in the guidance as well, that they're fully involved in the any difficult decisions or the development of any local protocols. I don't know if you'd agree with that, Roland.
Yes, I would, Tom, and I think, again, I've had a lot of inquiries personally on email and elsewhere. People tend to, and understandably, jump to the end game. Well, what will we do if somebody is COVID-19 positive and will not go along with the procedures that we think are reasonable in order to manage the infection risk? The people, quite often their mind jumps right to that end stage, and can we or can't we lock them in a room, for example, or use procedures that we would otherwise use for aggression and so on. So I think what our guidance clearly says is it starts with every person on the unit being engaged in a conversation about COVID-19, about the infection risks, about the precautions that we think are reasonable, and have that person engaged proactively in that conversation alongside a capacity assessment, and determine the extent to which they could participate in reasonable measures to protect people from infection. Now, I personally, in our intensive care unit and in our low secure unit played out our guidance, if you like, and it does work. The vast majority of patients will take reasonable steps, and the further down the line we get, and for those that are definitely COVID-19 positive or at least very likely to be, their risk of infection needs to be judged in the context of other kind of disturbance or acute situations that they present. So it's a serious risk to others in that context. And everything needs to be measured and proportionate and the least restrictive possible to manage the risk. And a quick example, if somebody was experiencing mania, for example, and for those reasons they found it difficult to stay exactly 2 meters away from people, well, that wouldn't necessarily, in my mind anyway, give a clear basis for their segregation or seclusion. But if you took 5 or 6 steps on from that in terms of disturbance and difficulty with infection risk attached to it, you can see a point at which, under the Mental Health Act Code of Practice, it might warrant seclusion or segregation. But we expect that to be for a very, very small group in very specific circumstances and very carefully detailed. So far, we've not come across that in my PICU or in our low secure unit, and it would be interesting to see if others have, and if they have, to write that up in 200-300 words and put it on the NAPICU website, as people have started to do, to see what we can learn from it.
So there is a question here leading on from that. So we have a patient on a section 3 who has a temperature and initially agreed to self-isolate but is no longer self-isolating. The patient's not been tested on the ward and there are other patients who have asthma. What would the options be? Seclusion and or lock his room. So I think that's going back to those primary, secondary and tertiary interventions, isn't it? So at first, the first thing to do is to make sure that there's a lot of information around for patients about COVID-19, about the measures that are in place. Then some initial screening, whether that's daily physical obs, temperatures, whatever's being recommended by your trust, and doing a capacity assessment. Has the patient got the capacity to be able to follow that guidance or not? If they have, or can you develop some kind of advanced statement to support them in doing that? When you move on from that, you need to do some risk assessments about, firstly, are they, what level of risk are they of developing severe complications? Have they got asthma, diabetes, heart failure, things like that? But also, based on presentation and their mental state, what risk would they be to other people, and then draw up a management plan. So like Roland said, if it's a manic person who's really disinhibited, wants to hug everybody, or it's someone who's a known risk of spitting, things like that, that can form part of your management plan. And then if someone does, I presume this patient who's got a temperature, they were asked to self-isolate whilst testing was arranged. So we would do that, and if a person's happy to do that and got capacity, then that's fine, you can just go along with that. The more difficult questions and considerations come, don't they, I suppose, when the person's not agreeing to that. So the stance that we've took and the legal guidance is backed us up is right at the far end of that spectrum. We've got somebody who's on a section who's unwell and they're presenting as a significant infection risk to others, and that behaviour, for I think, so one of the examples we've spoken about is a psychotic patient who feels, I don't know, the demons inside them or something, and needs to spit it out to other people. So they're the risk that they're presenting there is a risk to harm to others, but it's also related to the mental disorder. So you could consider whether, seclusion is relevant under the Mental Health Act to enable to promote the safety of other people. In between that, there's a bit more of a grey area that we've talked about, where somebody may have capacity, may still have a mental disorder, may have capacity, and understand what they're doing, but just don't want to go along with it, don't agree with it, and we're just wandering off and things like that. I think in those situations you need to have obviously discussions with the ethical committees, but there are still powers and guidance that should support you in isolating that patient. We talked about, you know, the chapter 26 of the Code of Practice applies to restrictive interventions. They're not a treatment for mental disorder, but you could argue that they can be applied if necessary within mental health hospitals, even if for risks that aren't a result of or a symptom or a manifestation of a mental disorder. And also we've referenced, you know, the healthcare, the coronavirus bill that is not fully applicable to us, but gives us some principles and some idea of how serious risks are, and some justification to say we need to isolate this person. We talked about this earlier, Roland, didn't we?
Yeah, we did, Tom. I think, again, people are, and you can understand why, they're deeply reassured by a binary view. Yes, we can lock somebody in a room, or no, we can't. The reality is, well, we could lock somebody in a room in circumstances where we can clearly justify it. And that is a particular set of circumstances that would apply before COVID-19 for anyone that we're aiming to seclude or segregate. So the infection risk is a serious risk to others that is seen in the context of the overall behavioural and mental state profile, and it could result in the justification for so doing. But we could not and do not support, and I don't think the law would be very favourable to someone that said, well, you're COVID-19 positive, you're not doing exactly what we tell you to do in terms of 2 meters or not to go into this area or that area, therefore we're going to lock you in a room. That would not necessarily, I don't think, be justifiable, in the same way as it probably wouldn't be in a nursing home or residential home or any other setting. But if the risk is calculated to be significant enough, and there is a consensus around that, and there is somebody's detained under the Act, and we need to use the interventions available to us for that level of risk, then it could be justifiable to lock that person in their room or segregate them. It's about what can be justified in the circumstances that is seen as proportionate and reasonable.
So I think sorry to interrupt, I think it'd be good to move to Mayura. I think there's a few questions that are coming along about ethical considerations, and I know that Megan has Mayura on the line. So if I just unmute Megan, we should hopefully be able to hear Mayura. Not unmuting it for some reason.
Oh, there you go. Mayura, do you want to start going off?
Yes, hi there. Am
I think everyone can hear you. Can everyone hear okay? Do you want to carry on, Mayura?
Okay, thanks. Hi there. Hello, everybody. I'm awfully sorry about technology letting me down at this end. So I'm connected via telephone, I think, and hopefully you can all hear me. My name is Mayura Deshpande. I'm a forensic psychiatrist down in Southampton. I'm also the National Specialty Advisor for Secure Care, Adult Secure Care for Nurse and Improvement. I chair the Royal College of Psychiatrists Ethics Forum, and we've written some specific ethics guidance for clinicians in terms of what we think COVID will throw up for all of us. Very quickly, just to say, as you're aware, the college has also published quite detailed and specific guidance for various mental health, learning disability and autism settings for clinicians on how to manage COVID, and that is on the college website. The section pertaining to secure hospitals and offender health, very quickly just to say that the issues for secure hospitals will be as for all other inpatient mental health services, and what we recommended specifically is that for secure inpatient services, Clinicians and teams should consider doing a specific and detailed risk assessment on each individual in hospital to establish their particular vulnerabilities, their medication requirements, their requirements and needs in terms of contact with their family and loved ones. And also focus in terms of teams and services on providing a therapeutic and leisure offer or therapeutic and leisure activity offer in-house. Because access to community resources is going to be limited for all of us, but particularly for our inpatients who are dependent on the Act. The advice from the college for the medical management of suspected and confirmed COVID for inpatients in secure wards is pretty similar to that for all other inpatients. One other consideration is for secure services and teams to think about proactively engaging with their local acute hospitals and where possible to draw up in anticipation a plan thinking about arrangements for transfer of patients to hospital when that is required, particularly thinking about patients who are on restriction orders and equivalent for other jurisdictions. Now, in terms of thinking about the ethics of things, which is going to be key, I suspect, in getting us through the next few months, for our secure hospital inpatients, I think this applies to all inpatients generally and all patients generally, but particularly for this population. We need to be really careful and try and understand how the various types of legislation all interface with one another, and be very careful and ensure that we use the Mental Health Act for mental disorders, that we use the Mental Capacity Act in the absence of capacity, as we do now, and that we use the emergency coronavirus bill powers for those circumstances. And of course, we still await the detailed operationalization of the emergency coronavirus bill. So currently, we are operating in a space where we don't have the operational detail of the emergency bill. And there is therefore a risk, I suppose, for all of us, particularly in very stressful and risky circumstances where we might be tempted to use other bits of legislation available to us, such as Mental Health Act. So that then brings me neatly on to the ethics advice that the college has published. And I guess the three things that are key for us, I mean, there are many other considerations and they're all again published on the college website, but the three things I'd like to flag are, first, it becomes even more important now than ever to ensure that there is equity of access for all individuals to coronavirus assessment, testing, and treatment. This is particularly important because there is a risk, I suppose, as ever, that individuals who have any disabilities or disorders might be seen to be lower priority. The government has been very clear that there is to be no such discrimination, and it is incumbent upon all of us to ensure that there is equity of access for our patients when it comes to assessment and treatment. We must also ensure that we make reasonable adjustments, and all agencies make reasonable adjustments for people with any types of disabilities. The second issue that is particularly key is that pandemic ethics will talk about the importance of public health and collective approaches. And of course, that's immensely important. That is our only hope of collectively ensuring that the virus doesn't spread any further and cause any further damage. However, we must recognize that public health and collective approaches in the context of pandemic ethics will bring a degree of restriction of ordinary freedom that we all take for granted, such as the current lockdown requirements. And while this is entirely correct and proper, we must also remember not to automatically consider the needs of individuals to be secondary to the needs of the community. And this, I suspect, is going to come up again and again. It has already come up, I think, this afternoon in some of the questions that have come up regarding how we might enforce isolation of individuals who decline to be isolated, even though we think they might have coronavirus. That's a good example. So, in terms of balancing the needs of the individual against the needs of the community and the needs of the collective body, that requires a balancing act and a careful consideration of both sides. And the third thing I've already alluded to, which is that as we go into these very unusual times and we have these emergency coronavirus powers that are there for public agencies, it is very important for clinicians to think about how we consistently and ethically apply various types of legislation that may be available to us. As I said before, Mental Health Act for mental disorders, we know this, we do this now. Mental Capacity Act for circumstances where there is no capacity. And the Coronavirus Emergency Bill for those circumstances, and particularly think about how these various types of legislation might interface with each other. I'm going to stop there and happy to take any questions.
Okay, so I think there have been some questions that come through. If you want to send some more through, as Mayura can answer this one. So we've had one come up that says, struggling with the PPE issues, can the college and NAPICU assist us and put some pressure nationally for the NHS Trust to accept the guidance?
I think, as we spoke about earlier, there's this huge debates and problems and things going on with PPE. There are some recommendations in our guidance, and we're working this week hopefully in improving those. I think what we can do then is obviously share those with trusts, but also Public Health England, NHS England, to see if that can have any influence. But more feedback from units and what has and what hasn't worked, and what the concerns are through the Quality Network Knowledge Hub or the question and answer section on NAPICU will really help with that, because we can share those with the links that we have got.
Shall we move on to hearing from Geoff now? Because I'm just thinking about the time that we have left, and then maybe we can finish on questions the rest of the session. Would that be best? So Geoff, did you want to continue on now?
Hello everybody, I'm so sorry that the technology has let me down my end. I haven't been able to sign in, but I've been listening to the conversation and would agree with a lot of the kind of comments that are being said. These are unprecedented times, and we are in the middle of something that none of us have ever seen, so we are charting territory that we've never been in before, and I think, as people have been saying, we need to do it carefully, proportionately and considerately. I just was joining the call because I was involved in the RCN inpatient guidance with very, very fast, jointly with the Royal College of Psychiatry guidance, and in fact the inpatient bit in the Royal College of Psychiatry is very much the same as the Royal College of Nursing, which I was involved with. I don't want to go on too much because I think a lot of stuff's been said. I think the only thing I would add is that the guidance is saying that, and I suspect there's a lot of people here from frontline wards, and that it's very, very important that whole organisations get behind frontline wards. We've been talking about ethics, we've been talking about individual patients, and what we see, this is a time really for the whole MDT to get around the ward, but the whole organisation as well. And we've been, one of the highlights of the guidance has been that organisations need to set up special committees that can assist wards directly and fast with individual problems with patient management, or indeed staff management as well. I think NAPICU and the Royal College of Psychiatry ourselves have been very careful not to make national guidance that is too restrictive. We have to give people flexibility within their own organisations to meet these problems. And I don't think any of us have the answers, but I think what I would really encourage wards is not to struggle alone, and that it's very, very important that we feed things up. NAPICU have put something on their website. It's really important if you've got a difficulty to go on there and look for advice in Safe Wards and Starwards and all sorts of other places. There are places that people can go to look for advice, and I think wards that will struggle are wards that are desperately trying to just manage by themselves. You should be pushing up to your organisation. You should be just asking for help from wherever you can get it, and that's with individual patients as well. The other thing I would just say about talking about individual patients is that wards are communities. They're communities of staff, communities of patients, and what you do to one patient, you effectively do to all patients. They will see that. And the very, very important thing is that we are proportional, that we are just, that we are open, transparent, and that patients can see that we are in these very difficult times trying to do the best that we can. I think we all agree that patients are active agents, that in many ways they will support us with whatever we're trying to do, as long as we keep them involved and informed. And as long as what we're doing is just, I think that will be a much kind of better outcome for everybody. I would say that I think the NAPICU guidance, I have to say, is excellent. I think it's, it doesn't answer all questions, it can't, but it certainly gives very good guidance. It gives people stuff to think about as they go through things. I would encourage organisations to look at their own state and their own needs and to adapt that to their own needs. I would say that for our own guidance as well. It is certainly not, and it's not like NICE guidance anymore, and CGC aren't going to come around and inspect you on this. This is all of us pitching in together to try and get through these incredibly, incredibly difficult times. But I think for anybody who's on the front line, the only thing I would say as well is that you are incredibly skilled, you're incredibly capable. I can honestly say, I think this is the best generation of inpatient workers I've ever seen. And I've been in this business a long time. These are terrible, terrible times. But I really do genuinely believe that we couldn't have a better set of staff. Even though these are very, very difficult things that you are facing, which none of us really know the answer to. The other thing I'd say about PPE is it's clear that, it's not good. All we need to do is just keep pushing up and putting pressure on powers that be so that certain things come through. But we also need to do that proportionally so that we get the outcome, which is more PPE and the best type of PPE. But as Roland says, there's a lot of guidance out there about what people can use. So yeah, I'm sorry to come late to the party, but I'm glad to be here and struggle with it in the same as everybody else. And yes, I'm open to any questions or hear what anybody has to say.
Okay, thank you, Geoff. We have had some more questions come through as you've been talking. So we've had one that's already answered the moderator chat. So it was about the Corona Bill does not say anything about NHS staff enforcing isolation. It only relates to police officers, immigration officers and public health officers. That's correct. We have referenced it to highlight the significance of the risk of infection. It is not for us to enforce, but can guide us. We've had one from Wendy that says it's important to provide meaningful activity as essential intervention as part of the whole team service provision, but this has become nearly impossible for many occupational therapists who are being included in the nursing numbers. While safety of ward is paramount, reducing occupational therapy provision is likely to result in increases of patient disturbance and therefore creates other types of risk. Is stronger guidance needed from NAPICU than the current mention?
Hello?
Geoff, are you taking that one?
Oh, I think stronger guidance. I think we are working in difficult times, and I think while people are probably looking for something more definitive, we do have to balance up the whole spectrum of legality and everything else. I think the NAPICU guidance is good, and I think it's for organisations to kind of put that into the best shape that they can. Many organisations are doing different things. I mean, what some areas do, for example, is having isolation wards. So we've got a kind of mixed pattern of how people are managing it, which is to be expected given that we have a very mixed estate. And I think anything that comes out which is stricter will bring, every time we kind of ratchet up the intensity of restriction, we also ratchet up the intensity of other unnecessary consequences. One of the typical ones, for example, if we really restricted somebody, and let's face it, our patients can abscond, we've got less staff, then we can make things worse. If we make COVID possible, people abscond. So everything has to be proportional. So I'm not blind to the difficulties that people are facing out there, but I'm saying that we do need to respond carefully, considerately, proportionately. And what I think we also need to do is bring our patient group on with us as much. And in that way, I think in an awful situation, we'll have a better outcome than otherwise. I know it's a fluffy answer, but I'm not fully signed up to really restrictive measures just yet.
Well, if I could say something on Wendy's point, is what I think would be helpful would be to use networks that we've got, like the NAPICU OT network or other OT networks, to find out what people are doing, what challenges they're facing, occupational therapy wise, and to see which groups or which activities can work and do work, and how we're getting around things with infection control and stuff. And the more information we can get in like that, perhaps we can make the guidance a little better, not more restrictive, but more give people more options and more guidance.
Okay, thank you. I'll move on to the next question. Has anyone made changes to their rapid tranquilization protocol, either in terms of changes to doses, first or second line drugs, or threats for using iron medication?
I think that's in the Royal Code of Psychiatry guidance, isn't it?
Mayura, do you have a response to that?
Hi, apologies, I was on mute. I think the general advice is specifically to be aware of the respiratory depressant effects of coronavirus infections, particularly in those in whom infection is suspected but not yet confirmed. I haven't yet seen a national change to rapid tranquilization advice or guidance yet, and I'm not aware if that is coming. However, I'm aware that a number of organizations internally have reviewed their own rapid tranq guidance and specifically inserted additional caution around the use of benzodiazepine. There is also the need to ensure that flumazenil is available.
Okay. Thank you. Oh, Tom, your microphone's muted.
Sorry, there's a section in the NAPICU guidance as well around medication, and just to echo what's just been said, if benzos are used, then short acting would be better, and the same with flumazenil. Need to make sure that that's available.
Okay. If suspected positive patient has capacity but non-compliant with isolation, is it ethical to discharge?
I would say it's a case-by-case decision, isn't it? It could be.
Should I quickly briefly come in on that one?
Yeah.
Yeah, so if I understood the question correctly, is if somebody has capacity and is non-compliant with infection control requirements, is it ethical that they be discharged? Was that the question?
Yeah.
Yeah.
Yes, well, I think it would be. Obviously, a case-by-case basis, every case is unique, and but I think if somebody was suspected as being COVID positive or confirmed as positive, if you look at the legal advice note attached to the NAPICU guidance, it makes specific reference to those that if you're in an institutional living or you're living on a consent, a capacitous basis, and you're unwilling or unable to go along with the requirements of that collective living, particularly in COVID-19 risk, then one could easily see the pendulum swinging towards discharge in the current climate, and which would probably be in the best interest of the individual and everybody else, but obviously on a case-by-case basis.
Okay, shall I move on to the next one? There's a lack of understanding in older adults with patients who are not detained under the Mental Health Act. Should they need isolation, however, are unable or unwilling to comply and pose a risk to others. What, if any, legislation would cover this, as the Mental Health Act has not been amended and best interests may not be relevant?
Well, there's an issue with the Capacity Act in a lot of this, is the decisions you make under the Capacity Act is for the best interests of that patient, and isolation in itself might not specifically be for the best interests of that patient. It's more for the best interests of everybody else, isn't it?
Yeah.
So, I mean, there's issues if the patient was at risk from other people, from how they were presenting. But again, it's back similarly back to the guidance that we've done. I think the same thresholds and the same primary, secondary and tertiary interventions would apply in older adults as they would in working age adults. Our document is specifically, you know, aimed at PQs, so I'm sure there would have to be amendments and other considerations in older adult wards, but broadly I think the principles would be the same.
I would agree, Tom. I think the guidance does make a provision for it. What it doesn't do is give us binary. It doesn't say, you know, person does X, therefore we can do Y, but it sets out a framework that ends its quite restrictive interventions actually, but only in very specific circumstances that can be well articulated and justified, which is actually what the code requires without COVID-19. But COVID-19 brings that additional layer of consideration to it. But I think the guidance does cover that kind of scenario.
Okay, I think that's. Oh no, we do have another question. What about areas such as Republic and Northern Ireland that does not have a Capacity Act and also has certain diagnoses excluded from detention?
That's a good question.
Tom, could I be cheeky and ask you to repeat the question because I couldn't quite make it out?
What about areas such as the Republic and Northern Ireland that do not have a Capacity Act and also have certain diagnoses excluded from detention? So we did have some queries from Wales and Scotland, didn't we, that are just looking at the moment about would the same guidance apply there?
Well, personally, I think it would, because the guidance is basically a set of principles, and most liberal democracies have similar principles attached to the management of people with mental health problems or prisoners or anyone actually that is in the custody of the state or eligible to be in custody of the state. And those principles always start with the least amount of infringement and restriction possible, balanced against the extent of risks and best interests of other people. So I think our guidance alongside those principles of least restriction. And again, the Article 8, for example, of the Human Rights Act, which is right to privacy and family life, that's a qualified right, meaning it can be interfered with only in circumstances that are proportionate and justifiable. Article 3 would be inhumane or unusual treatment. So I think our guidance is consistent with its principles, which is least restriction, while accepting there could be some hard choices in very specific circumstances, hopefully very rare circumstances, which could involve quite a lot of restriction. So I think it probably would apply to different legal frameworks on the basis that those principles are upheld by most liberal democracies.
Can I just go back to one question that was asked earlier quickly?
Mm-hmm.
So there was one, what experience has the forum had of trying to use a swab as part of the process of screening of mental health patients? I think it is quite important because I think I can see questions raised about this, about people who are refusing to be asymptomatic and are refusing to be swabbed. What do we do? And I just wanted to be quite clear that I'm not aware of any guidance or legislation that allows us to force screening or swabbing on patients. And aside from the lack of legal guidance, it's a dangerous procedure to do if someone's resisting. So I think if somebody is symptomatic and is refusing a swab, then you isolate and do the 7-14 day period. I don't think we can go around enforcing swabbing on people.
We've only got a couple more minutes left until it's 2 o'clock, so I'll just quickly go through some of these questions. A lot of trusts have gone smoke-free, and most, if not all, of our patients use smoking as a way of coping. With some restrictions on leave, will this policy be reviewed, as we need to see to be practicing in a least restrictive way?
I think the smoking is very much a danger to people if they contract this disease. Smoking, obviously, the disease of the lungs, and smoking is, I mean, I think how people manage this individually is up to them, but people who smoke are in danger. So I think that we need to also inform patients of that reality, because it is quite clear that smoking is massively contraindicated with this particular virus. Smoking doesn't kill them as well. So I think the general principle is that we are actually tightening down on smoking. I think the other thing is, for lots of areas, smoking is, you know, it's a traditional community activity, and that certainly, if you do decide to go down the line of allowing your patients to smoke anywhere, and I'm saying very clearly that the national guidance is not to, then you certainly shouldn't let them congregate, and staff who are with them should be very, very careful. I think the general principle is that we need to try and find a way to actually cut down on the smoking to protect people.
Okay, thank you.
I know that I suspect that's not the answer the person wanted, but that is the position.
Thank you. And we've got 3 questions about restraint, so I'll just kind of bring them all together. So what is your opinion of trusts continuing to provide restraint training to staff? What are you doing about this? Someone else said, I was wondering if training is still going ahead for PMVA. If so, should trainers be wearing masks, and should group numbers be decreased, e.g. maximum number of students? And another person, restraint training, I'm part of the positive and safe group. Nearly all areas have ceased with this training, CRT being offered as an alternative.
Shall I have a go at that, Tom?
Go on then.
Yeah, if I think I've heard the question correctly, it's about PMVA or physical interventions and the extent to which training should continue, and if so, in what circumstances. Did I get that right? Is that basically it?
Yeah,
well,
pretty much.
The position that many are taking at the moment is training programs are being postponed rather than cancelled, and the theory being that we should arrive at a place in the coming weeks where we'll know through antibody tests, or it should be possible at some point soon, to understand more about immunity in members of staff and the extent to which they got antibodies and maybe have had the illness. Secondly, I think as testing becomes more prolific, there will be releasing of social distancing restrictions in some areas and not others, once we understand the epidemiology more clearly of the virus. But then my last comment on that might be, if this is going to be a risk that prevails for at least 18 months until there's a vaccine, we probably ought to start to introduce PPE to PMVA and PI training, whichever restraint system is used, because the reality might be that that will be increasingly needed. And there may well need to be a rethink about infection risk during physical intervention as a separate set of circumstances, which techniques, if you like, or which methods are less likely to transmit both from staff member to recipient or recipient to staff member. And if there is a time to try and create activity programs, engagement programs, positive environments in which cooperation is maximised, this is probably one of the best times to pursue that agenda. And I think our guidance says the more or the less options there are external to the hospital, the more options there ought to be for meaningful positive engagement within the hospital. But yeah, so that would be first thinking on PMVA training.
Okay, I think we're going to have to leave that now. Thank you everyone for attending. I just want to let you know that we'll be opening an online platform towards the end of the week that is specific to COVID-19 and managing that within various different settings. So if everyone's interested, I can send a link out to that join. I also just wanted to thank everyone for all their questions, and I think it'd be really good if I spend some time writing this up and writing out the answers so that it's sort of easier to digest. And obviously thank you to our speakers, so to Tom, Geoff, Roland and Mayura, for giving us some guidance and starting off these webinars. So yeah, thank you everyone.
Thank you.
Thank you. Thanks everybody out there.
Bye.
Bye. Bye. Bye.